Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. A comprehensive understanding of opioids is paramount for safe and effective patient care. This curriculum introduces the multifaceted world of opioids, covering their rich history from ancient medicinal use to the current public health crisis. We delve into essential terminology differentiating opiates from the broader class of opioids, and explore the intricate pharmacology of opioid receptor subtypes, mu, kappa, delta, and their signal transduction mechanisms. A critical focus is placed on the diverse clinical presentations, including both therapeutic effects and the life-threatening toxicities such as respiratory depression, as well as the unique characteristics of specific opioid agents. Finally, we examine the pivotal role of opioid antagonists, particularly naloxone, in overdose reversal, and discuss crucial prevention and harm reduction strategies, including medication-assisted treatment for opioid use disorder, reflecting the complex interplay between pharmacology, societal factors, and public health policy. Let's discuss the key aspects of opioid pharmacology, historical context, and clinical management as outlined in the provided objectives. First, understanding the distinctions between opiates, opioids, and narcotics is essential for precise communication in clinical practice, including recognizing examples of each. Tracing the evolution of opioid use, from early medicinal use to societal issues like the opium wars and legislative measures, such as the Harrison Narcotics Tax Act, provides important background. Next, we delve into the pharmacodynamics of opioid receptor subtypes, mu, kappa, delta. Activation of these receptors underlies both therapeutic effects, such as analgesia, and adverse effects, including respiratory depression and mental status depression. Recognizing key risk factors for overdose, like previous substance use, mental health issues, and social determinants, helps in implementing harm reduction strategies. Critical interventions include naloxone distribution and comprehensive treatment for opioid use disorder. Clinicians must be able to identify the hallmark signs of opioid toxicity, respiratory depression, meiosis, and altered mental status, and understand the diagnostic considerations. Comparing pharmacokinetics, particularly the durations of action of naloxone versus naltrexone, informs their use in different clinical scenarios, from acute overdose management to relapse prevention. When administering naloxone, dosing strategies should be tailored considering patient dependence, the specific opioid involved, e.g., fentanyl or buprenorphine, and the goal of restoring adequate ventilation. Awareness of the pharmacological properties and toxicities of opioids like meperidine, tramadol, and fentanyl is crucial. Each presents unique risks such as seizures or chest wall rigidity. Furthermore, understanding the characteristics of methadone and buprenorphine, including their receptor activity and safety profiles, guides their use in opioid use disorder treatment. Lastly, naltrexone's limitations in acute overdose scenarios, due to its long duration and risk of precipitating severe withdrawal, must be appreciated. The distinction between opiates and opioids is crucial in understanding pharmacology, law enforcement perspectives, and substance use terminology. Opiates are specifically alkaloids naturally extracted from the opium poppy, Papaver somniferum, including substances like morphine, codeine, and thebaine. These natural compounds have been used for millennia for their pain-relieving and sedative properties. On the other hand, opioids encompass a much wider range of compounds, including natural, semi-synthetic, and synthetic agents that interact with opioid receptors, eliciting similar effects. Endogenous peptides such as enkephalins, dynorphins, and endorphins are naturally produced within the body and bind to these receptors to modulate pain and mood. Semisynthetic opioids like heroin, oxycodone, and hydromorphone are derived from natural opiates through chemical modification, designed to enhance potency or duration of action. Synthetic opioids, including fentanyl and methadone, are fully man-made, often designed for specific medical or illicit purposes. The term narcotic, initially referring to sleep-inducing xenobiotics, is now broadly used by law enforcement and the public to denote any illicit psychoactive substance, including, paradoxically, cocaine. The medicinal use of opium dates back to the 4th century BC, with the earliest written documentation found in the Ebers Papyrus around 1500 BC. Over centuries, opium was reformulated into preparations like laudanum, paregoric, Dover's powder, and Godfrey's cordial, consistently used for profound analgesia and sometimes for non-medical psychoactive effects. A significant development occurred in 1804 when morphine was isolated from opium by Armand Sequin. Its name, derived from Morpheus, the Greek god of dreams, reflects its sleep-inducing properties. Later, in 1874, Charles Alder-Wright synthesized heroin, diacetylmorphine, from morphine, ironically in the pursuit of a safer, less addictive opioid. Bayer, a German pharmaceutical company, further legitimized heroin's medicinal role by marketing it as an antitussive in 1898. Despite the development of various opioid-like xenobiotics promoted for their perceived advantages over morphine, these often fell short of expectations, particularly concerning their potential for abuse and addiction. The history of opium and its derivatives is marked by humanity's continuous quest for pleasurable effects, leading to significant societal issues. Opium smoking, for instance, became so problematic in China by the 1830s that it led to the Opium Wars with Britain. In the United States, mounting concerns over addiction and overdose prompted the enactment of the Harrison Narcotics Tax Act in 1914, which criminalized the non-analgesic use of opioids. Despite extensive legislative and other efforts since then, the recreational and habitual use of heroin and other opioids has remained an epidemic, now standing as a leading cause of death in the United States. The development of opioid receptor antagonists was driven by the urgent need to combat the adverse effects associated with opioid agonists, especially amid rising cases of abuse and overdose in the 20th century. Early on, the key insight was that minor structural changes to opioid receptor agonists could transform them into antagonists, which marked a significant breakthrough in pharmacology. The first synthesized antagonist was enalylnorkidine in 1915, laying the foundation for subsequent developments. In the 1940s, enalylnormorphine, nalorphine, was introduced and became widely used to counteract the negative effects of opioid agonists. However, its mixed agonist-antagonist profile was only fully understood by 1954. Advances in understanding the structure-activity relationships then led to the creation of naloxone in 1960 and naltrexone in 1963, which are currently the main antagonists used in clinical practice. Although other antagonists like nalmefene emerged, some were eventually discontinued in the U.S. market. More recently, peripherally restricted antagonists such as methylnaltrexone and naloxegol have been developed. These agents specifically target opioid-induced constipation by acting outside the central nervous system, thereby reversing effects without crossing the blood-brain barrier and avoiding CNS withdrawal symptoms. The opioid crisis in the United States has become a significant public health concern over recent decades. The surge in prescription opioids has played a central role in this epidemic. Opioid poisoning has now emerged as the leading cause of injury-related deaths in the country. Data from 2011 shows that opioids involved in poisoning fatalities accounted for 41% of such deaths. Studies from the Drug and Alcohol Information System highlight a dramatic increase in prescriptions, diversion, and abuse of opioids from the year 2002 to 2010. Although there was a slight decline between 2011 and 2013, this suggests some early effectiveness of intervention efforts. Notably, deaths resulting from prescription drugs, mostly opioids, surpassed those caused by motor vehicle accidents as early as 2009. Between the years 2000 and 2015, overdose deaths rose by 137%, with fatalities related to opioids, including both prescription painkillers and heroin, rising by a staggering 200%. These trends underscore the urgent need for comprehensive strategies to address and mitigate the ongoing opioid crisis. The transition from prescription opioids to illicit substances highlights a concerning shift in patterns of substance use, emphasizing the complexity of the opioid crisis. Efforts aimed at reducing the availability of prescription opioids have successfully led to a decrease in deaths related to these drugs. However, these measures have inadvertently contributed to an increase in heroin use, as many individuals seek accessible and affordable alternatives. This substitution underscores the necessity of implementing comprehensive strategies that address not only prescribing practices, but also the underlying causes of opioid dependence. Furthermore, the emergence of synthetic opioids such as non-pharmaceutical fentanyl and its analogs has significantly intensified the crisis. These potent substances are often manufactured abroad and imported into the U.S., frequently used to adulterate heroin or craft counterfeit pills. Their high potency presents substantial challenges for detection and treatment, with some analogs being up to 10,000 times stronger than morphine. This potency necessitates higher doses of naloxone for overdose reversal and complicates forensic attribution of overdose deaths. Overall, these developments underscore the urgent need for enhanced monitoring, regulation, and education efforts to combat the evolving landscape of opioid-related harm. The development of abuse-deterrent formulations represents a significant step forward in addressing the widespread problem of opioid misuse. These formulations are designed to be resistant to tampering methods such as crushing or dissolving, with the aim of making it more difficult to misuse the medication through techniques like insufflation or injection. Despite this, the actual effectiveness of these formulations in clinical settings remains uncertain. Critics highlight that information on how to circumvent the tamper-resistant features is widely accessible, which could potentially undermine their intended purpose. Furthermore, most cases of addiction and increased sensitivity to pain are associated with the oral ingestion of these medications in their original, intact form. This suggests that combating abuse requires a comprehensive approach that goes beyond simply engineering deterrent features into the formulations. The mu-opioid receptors, also known as mu-opioid receptors, are essential components in the mechanism of action for many opioid medications used in medical settings. These receptors serve as the primary sites where both opioid agonists and antagonists exert their effects. The mu receptor is divided into two main subtypes, mu1 and mu2. Each subtype mediates different pharmacological outcomes. The mu1 subtype primarily mediates pain relief at the level of the brain, known as supraspinal analgesia. Besides providing pain relief, activation of the mu1 receptor is associated with feelings of euphoria and sedation, which can contribute to the addictive potential of opioids. Interestingly, this subtype also influences the release of prolactin and can exert anti-inflammatory effects in the peripheral tissues, adding to its complex physiological functions. In contrast, the mu2 subtype is responsible for pain relief at the spinal cord level. Activation of the mu2 receptor is also linked to many adverse effects commonly associated with opioid use. These include respiratory depression, which is a leading cause of overdose deaths involving opioids. Other side effects include constriction of the pupils, constipation, itching, and a slow heart rate. The mu2 receptors are located in the medulla, where they influence respiration and cough reflexes, and in the gastrointestinal tract, which explains the common gastrointestinal side effects. Understanding the distinct roles and locations of the two subtypes helps in developing targeted treatments that aim to maximize pain relief while minimizing adverse outcomes. This detailed understanding emphasizes the importance of designing drugs that specifically target these receptors within the context of opioid pharmacology. Kappa receptors play a crucial role in various physiological processes, primarily through their interactions with different subtypes and endogenous ligands. The main endogenous ligand for these receptors is dynorphin A, which activates the receptors and triggers specific responses depending on the subtype involved. The kappa receptor with the first subtype is mainly responsible for spinal analgesia, constriction of the pupils, and increased urination. These effects are largely due to the inhibition of antidiuretic hormone release. This suggests that targeting the first subtype could be beneficial in managing certain types of pain and ocular conditions, although their impact on urination indicates potential side effects related to fluid balance. The second subtype's activation is associated with feelings of discomfort and hallucination-like states, highlighting its role in mood regulation and psychosis-like conditions. This emphasizes the need for caution when developing drugs that specifically activate or inhibit this subtype, as unintended activation could lead to adverse mental health effects. The third subtype primarily provides pain relief from areas above the spinal cord. Interestingly, nalorphine, an early opioid antagonist, mainly acts through this subtype's receptor activation. This highlights the unique mechanisms of pain relief mediated by kappa receptors, which are distinct from those mediated by mu receptors. Importantly, pain relief induced by kappa receptor activation cannot be reversed by mu receptor antagonists, indicating a separate and potentially valuable pathway for pain management. Overall, understanding these subtypes and their specific functions is crucial for developing targeted therapies that minimize adverse effects. The distinct roles of the first, second, and third subtypes of kappa receptors underscore the complexity of this system and its potential as a therapeutic target. The delta receptors, also known as DOP or opioid receptor 1, are primarily activated by endogenous ligands called enkephalins. These receptors are divided into two subtypes, delta 1 and delta 2, each playing a crucial role in mediating various physiological effects. Activation of delta receptors contributes to pain relief at both spinal and higher brain levels. They are also involved in suppressing cough and modulating motor activity, mainly by influencing the release of dopamine within the nigrostriatal pathway. In addition to delta receptors, there exists a distinct family of receptors known as nociceptin or orphanin FQ receptors. These receptors are associated with anxiety reduction and pain relief, highlighting their significance in pain regulation and emotional responses. Overall, understanding the diverse roles of delta and nociceptin receptors can enhance our knowledge of their potential as therapeutic targets for treating pain, motor disorders, and anxiety-related conditions. At a cellular level, all major opioid receptor subtypes are part of the G protein-coupled receptor superfamily. When an agonist binds to these receptors, it activates G proteins, which then initiate several key processes. One process involves reducing the activity of the enzyme adenylate cyclase, leading to decreased production of cyclic adenosine monophosphate, a molecule involved in many signaling pathways. Another process results in the closing of calcium channels, which reduces the release of neurotransmitters, thereby diminishing neuronal communication. Additionally, the activation of G proteins causes potassium channels to open, leading to hyperpolarization of the cell membrane and an indirect reduction in neuronal activity. Notably, opioids can act in a bimodal fashion. At very low concentrations, activation of mu opioid receptors may have an excitatory effect, potentially increasing pain, which is known as an anti-analgesic effect mediated by stimulation of GS proteins. However, at typical analgesic doses, the inhibitory effects predominate, resulting from coupling with inhibitory GO proteins. Opioids are broadly classified based on their origin and receptor activity. Natural opiates are derived directly from the opium poppy, with examples including morphine and codeine. Semisynthetic opioids are created through chemical modification of natural opiates, and examples of these include heroin, oxycodone, and hydromorphone. Synthetic opioids are chemicals not derived from opiates, but they are capable of binding to opioid receptors and producing opioid effects. Notable examples are methadone and fentanyl. There are also different types of opioid receptor activity. Partial agonists, such as buprenorphine, display partial agonism at the mu receptor and often have antagonistic effects at kappa or delta receptors. Mixed agonist-antagonists, like pentazocine, act as kappa receptor agonists and mu receptor antagonists. Additionally, there are antagonists, which are agents that bind to opioid receptors without producing any intrinsic activity. These agents block the effects of other opioids and include drugs such as naloxone, naltrexone, methylnaltrexone, and naloxegol. The pharmacokinetic profiles of opioids and their antagonists play a significant role in their clinical use. For example, naloxone has a relatively short duration of action, typically lasting between 20 and 90 minutes. In contrast, naltrexone is much longer acting, with effects that can last approximately 24 hours. This discrepancy in pharmacokinetics is especially important when administering naloxone to reverse toxicity caused by long-acting opioids such as methadone, which has a duration of effect ranging from 12 to 24 hours. In such cases, there is a risk of resedation and recurrent opioid effects, which necessitates continuous monitoring of the patient's heart and lung function. Naloxone is usually given through injection because of the extensive first-pass metabolism in the liver, whereas naltrexone can be administered orally or via intramuscular injection. When discussing the clinical manifestations of opioids, it is essential for pharmacy professionals to understand their wide-ranging pharmacological effects. These encompass both the therapeutic benefits and the potential toxicities associated with opioid use. Opioids are widely recognized for their effectiveness in alleviating pain and reducing human distress. However, their psychoactive properties also carry a significant risk of abuse. The unpredictable nature of effective therapeutic doses and toxic doses becomes more apparent with chronic use and the development of tolerance. This underscores the importance of thoroughly understanding the clinical presentation of opioid effects. At sufficiently high doses, all opioid agonists generally induce a characteristic set of signs known as the opioid toxic syndrome. These signs include a depression of mental status, a reduction in the rate of breathing and the volume of air moved with each breath, known as hypoventilation. Meiosis, or pupillary constriction, and decreased bowel motility are also common. These effects are mainly caused by the activation of the mu opioid receptor, which leads to a reduction in sympathetic autonomic tone. Respiratory depression is the primary adverse event associated with excessive opioid dosing and is a leading cause of death following overdose. Opioid agonists reduce the sensitivity of the medullary chemoreceptors to elevated carbon dioxide and decreased oxygen levels, resulting in diminished ventilation. In high doses, full agonists can cause apnea. Although opioid agonist-antagonists and partial agonists generally have a ceiling effect on respiratory depression, life-threatening hypoventilation can still occur, particularly in children. Changes in tidal volume often precede a decrease in respiratory rate, making respiratory rate alone an unreliable indicator of ventilatory compromise. Mental status depression and sedation are common and hallmark signs of opioid toxicity, with patients presenting from drowsiness to coma. Meiosis, or pupil constriction, is a relatively consistent finding due to complex excitatory effects on parasympathetic nerves. However, pupil dilation can occur in certain situations, such as in patients using heroin combined with cocaine or those experiencing asphyxia or hypoxic encephalopathy, indicating that meiosis alone cannot solely confirm opioid poisoning. Opioids often cause gastrointestinal effects by reducing gastrointestinal motility, leading to constipation through their action on specific receptors in the periphery. Medications such as methylnaltrexone, alvimipam, and naloxegol are used to reverse bowel dysmotility without affecting central pain relief, as they do not cross the blood-brain barrier. Nausea and vomiting are also common, especially with morphine, though the effectiveness of opioid antagonists like naloxone in preventing these side effects is inconsistent. Cardiovascular effects typically include mild reductions in blood pressure due to dilation of blood vessels and a slowing of the heart rate owing to decreased central nervous system stimulation. Severe hemodynamic disturbances are usually secondary to hypoxia rather than direct effects. Histamine release, which is mediated by nonspecific activation of mast cells, can contribute to hypotension, with certain opioids like meperidine causing more pronounced effects, while fentanyl has minimal impact. Some opioids, such as propoxyphene, can also be directly cardiotoxic, leading to abnormal heart rhythms and prolongation of the QT interval. Opioid overdose is frequently associated with acute respiratory distress syndrome, although its exact causes are complex. The administration of naloxone may reveal or unmask the syndrome, which could have been induced by the opioids themselves but hidden by respiratory depression. Other mechanisms include negative intrathoracic pressure resulting from effortful inspiration against an obstructed airway and damage caused by hypoxia, leading to increased permeability of the alveolar capillary barrier. Movement disorders, such as muscular rigidity, can occur rapidly after intravenous injection of high-potency opioids like fentanyl. This rigidity, especially involving the trunk, can impair chest wall movement and worsen hypoventilation. These effects are generally reversible with the use of opioid antagonists. Seizures are a rare but serious manifestation of opioid overdose or use. They may result from hypoxia or a direct effect of the drug or its metabolites. For example, metabolites of certain opioids like normeperidine and drugs like tramadol are known to be proconvulsant. While naloxone can reverse seizures caused by morphine in neonates due to their immature blood-brain barrier, it is usually ineffective against seizures induced by meperidine or tramadol and might even increase the risk of seizures in cases of tramadol overdose. Chronic opioid use can lead to various endocrine effects, including hypofunctioning of the hypothalamic pituitary gonadal axis, which may cause reduced libido, erectile dysfunction, hot flashes, depression, anemia, hair loss, and weakened bone structure. Opioids can suppress corticotropin-releasing hormone, resulting in adrenal insufficiency, and may also increase prolactin levels, leading to gynecomastia. Although rare, rapid progressive hearing loss has been reported in heavy users of opioids like hydrocodone, oxycodone, and methadone. Chronically, opioids can cause hyperalgesia, an increased sensitivity to pain, which may require escalating doses of analgesics. This condition differs from tolerance, where the drug gradually loses effectiveness. Hyperalgesia reflects an intrinsic amplification of pain. Prolonged immobility due to opioids can lead to serious complications such as muscle breakdown, cerebral hypoxic ischemic injury, delayed white matter injury following hypoxia, and aspiration pneumonia. Opioid poisoning is primarily diagnosed based on clinical evaluation. Healthcare providers rely on the patient's medical history, physical examination, and the patient's response to naloxone. Routine blood and urine drug tests often have limited immediate clinical value because of potential cross-reactivity with other substances and the time it takes to receive results. However, these tests can be useful for monitoring addiction therapy. It is also important to distinguish opioid poisoning from other conditions that cause decreased mental awareness, such as low blood sugar, lack of oxygen, hypothermia, or poisoning by other substances like clonidine or benzodiazepines. Recognizing these diverse clinical signs is essential for pharmacy students and healthcare practitioners, enabling them to manage patients exposed to opioids safely and effectively, whether for therapeutic purposes or in overdose situations. During specific overdose or clinical events, understanding which opioid is involved can help in developing targeted treatment plans and considerations. Meperidine is a synthetic opioid that causes significant euphoria and has a high potential for addiction. Many healthcare institutions have removed it from their formularies for this reason. Its metabolite, normeperidine, is a proconvulsant, meaning seizures caused by meperidine toxicity should be anticipated. Patients who use high doses of meperidine are at increased risk of developing normeperidine toxicity, especially if they have impaired kidney function. Additionally, meperidine inhibits the reuptake of serotonin, so when combined with other serotonin-enhancing medications, it may lead to serotonin toxicity. This drug was the first to highlight many significant issues, chiefly serotonin syndrome, and also played a role in the enactment of the Libby-Zion law. Tramadol is a synthetic pain reliever that acts through multiple mechanisms, both opioid and non-opioid. It inhibits the reuptake of norepinephrine and serotonin, and its active metabolite, which is formed through the process catalyzed by the enzyme CYP2D6, is a mu-opioid receptor agonist. The effectiveness of tramadol varies among individuals because the activity of CYP2D6 varies widely. Tramadol toxicity can also lead to seizures. In cases of tramadol overdose, naloxone may be administered based on an unknown ingestion, but seizures that occur should be managed aggressively with benzodiazepines. Tapentadol is another synthetic pain reliever that, like tramadol, acts through both opioid and non-opioid mechanisms. It has strong mu-opioid receptor activity and inhibits the reuptake of norepinephrine but not serotonin, which means it does not require activation. Similar to tramadol, tapentadol can cause seizures. Dextromethorphan is a semi-synthetic opioid that acts as a non-analgesic cough suppressant. When taken in high doses, it can induce sedation and a dissociative state similar to that caused by phencyclidine, commonly known as PCP. This effect is due to its active metabolite, dextrorphan, which functions as a non-competitive antagonist at N-methyl-D-aspartate receptors. Dextromethorphan is often misused for its psychoactive effects. Codeine, a naturally occurring opioid, is frequently combined with acetaminophen and used as a cough suppressant. To exert its effects, codeine must undergo demethylation to morphine through the action of the enzyme cytochrome P452D6. Fentanyl is a synthetic opioid that is considerably more potent than heroin. Despite its high potency, similar doses of naloxone can reverse respiratory depression caused by fentanyl as effectively as with other opioids. This is because fentanyl binds to the mu-opioid receptor with an affinity comparable to morphine and naloxone. Chronic users often report that fentanyl produces effects that are subjectively similar to those of heroin. This similarity may explain why fentanyl has a higher prevalence as a drug of abuse among anesthesiologists and why fentanyl and its analogs are increasingly appearing in communities as alternatives to heroin. Rapid infusion of fentanyl can also cause chest wall rigidity. Morphine is poorly absorbed when taken orally due to extensive first-pass metabolism in the liver. It is primarily metabolized into morphine-3-glucuronide and, to a lesser extent, into morphine-6-glucuronide, both of which are excreted by the kidneys. While morphine-3-glucuronide does not activate opioid receptors, morphine-6-glucuronide is a mu-opioid receptor agonist and likely contributes to the pain-relieving effects of morphine. In experimental animals, injecting morphine into various regions of the brain can induce epileptic activity that is not inhibited by naloxone. In humans, cases of morphine-induced seizures have primarily been reported in neonates, probably due to the immature. Heroin, also known as diacetylmorphine, was first synthesized from morphine in 1874. It was ironically introduced by the Bayer Pharmaceutical Company as a cough suppressant. Heroin is known for producing a greater sense of euphoria than morphine itself. The abuse of heroin has become a global epidemic and is one of the leading causes of death in the United States. This issue is often worsened by the reduced availability of prescription opioids, which prompts users to seek cheaper, illicit alternatives. Street heroin frequently contains adulterants such as caffeine or barbiturates. Its widespread use through intravenous injection is associated with severe medical complications, including hepatitis, endocarditis, and acquired immune deficiency syndrome. Additionally, the use of a combination drug known as a speedball, which contains heroin and cocaine, can result in unpredictable pupillary responses. Oxycodone is frequently combined with acetaminophen, as seen in medications like Percocet. Its extended-release formulations, such as OxyContin, have historically been susceptible to abuse, especially when individuals crush the tablets to bypass the controlled release mechanism. This issue prompted the development of abuse-deterrent formulations. However, their effectiveness in preventing addiction from ingesting intact tablets remains uncertain. Hydrocodone is also commonly combined with acetaminophen in medications such as Vicodin and is used as an antitussive. Hydromorphone is a potent opioid medication used for managing chronic pain. Oxymorphone is an opioid receptor agonist that is structurally related to morphine. It also serves as a precursor for the synthesis of opioid antagonists such as naloxone and naltrexone. Nalorphine was an early semisynthetic opioid antagonist synthesized in the 1940s. It is recognized for its mixed agonist-antagonist profile and has been used to reverse the adverse effects associated with opioid agonists. Buprenorphine functions as a partial agonist at the mu-opioid receptor, demonstrating a high binding affinity. It also exhibits antagonistic effects at kappa and delta opioid receptors. While buprenorphine is effective as an analgesic in patients who have not previously used opioids, its strong receptor binding can trigger withdrawal symptoms in individuals dependent on opioids. The reversal of buprenorphine-induced respiratory depression with naloxone is not linear. Doses of 2 to 4 milligrams administered intravenously are effective, but doses exceeding 5 milligrams can paradoxically worsen respiratory depression. Buprenorphine is a crucial component of medication-assisted treatment for opioid use disorder, often combined with naloxone in the formulation known as Suboxone to discourage intravenous misuse. Children are at high risk if crushed tablets of this medication are injected. Nalbuphine functions as an agonist at kappa-1 and kappa-3 receptors, producing analgesia, while it acts as an antagonist at the mu receptor. Pentazocine is a kappa agonist and mu antagonist, which allows it to provide pain relief in patients who have not previously used opioids. However, in individuals dependent on mu opioids, it can induce withdrawal symptoms. Additionally, pentazocine is known to cause dysphoria and psychosis. Opioid antagonists are crucial in the comprehensive management of opioids. They are particularly important in addressing critical issues such as overdose and addiction. Understanding their history, pharmacological details, clinical applications, and potential adverse effects is essential in pharmacy education. These aspects help ensure that these agents are used judiciously and effectively, promoting better patient outcomes. The development of opioid receptor antagonists began in the 20th century, primarily in response to the rising incidences of opioid abuse and overdose. Initial research identified that minor structural modifications to opioid receptor agonists could produce antagonist activity. The first opioid antagonist synthesized was enalylnormorphine, which was created in 1915. In the 1940s, enalylnormorphine, also known as nalorphine, was developed and became widely used to counteract the adverse effects of opioid receptor agonists. Its mixed profile of agonist and antagonist activity was not fully understood until 1954. Nalorphine primarily interacts with the kappa-3 receptor subtype, producing supraspinal analgesia. Further structural refinements led to the synthesis of naloxone in 1960 and naltrexone in 1963. These two agents are currently the most commonly used opioid receptor antagonists in clinical practice. Additionally, a derivative of naltrexone known as nalmefene, which features a 6-methylene group, was developed. However, it was withdrawn from the United States market in 2008. More recently, research has focused on peripherally restricted opioid antagonists such as methylnaltrexone and naloxegol. These agents were designed to treat opioid-induced constipation without causing withdrawal symptoms in the central nervous system. Since the mid-1990s, there has been a steady increase in the use of naloxone, especially with the resurgence of the opioid epidemic. Naloxone is often prescribed or directly dispensed to individuals at risk of overdose and can also be administered by bystanders in emergency situations. Regarding the pharmacology of opioid antagonists, these substances are structural analogs of opioid receptor agonists. They are created by substituting the N-methyl group on an opioid agonist, such as morphine or oxymorphone, with a larger functional group. For example, naloxone and naltrexone are derivatives of oxymorphone, altered to serve as antagonists rather than agonists. Opioid receptor antagonists are substances that act as pure competitive antagonists at the mu, kappa, and delta opioid receptors. These antagonists bind effectively to these receptors, preventing opioid agonists, partial agonists, or mixed agonist-antagonists from binding. Unlike agonists, these antagonists do not produce any independent action on the receptors. Their most significant activity occurs mainly at the mu receptor, which is responsible for effects such as pain relief, sedation, constriction of the pupils, feelings of euphoria, respiratory depression, and reduced gastrointestinal motility. Higher doses of these agents are required to influence the kappa and delta receptors. The kappa receptors are involved in spinal analgesia, pupil constriction, dysphoria, anxiety, nightmares, and hallucinations. The delta receptors mediate pain relief and hunger. In patients who are not dependent on opioids, or in those who are opioid naive or not dependent on opioids, these agents typically have no significant effect. The pharmacokinetic profiles of opioid receptor antagonists vary significantly. Naloxone has a duration of action of approximately 20 to 90 minutes and must be administered by a parenteral route, which includes intramuscular, intravenous, endotracheal, subcutaneous, intranasal, or intraosseous methods, due to extensive first-pass hepatic elimination. Naltrexone, on the other hand, has a substantially longer duration of action of about 24 hours and can be administered orally. Its half-life is approximately 10 hours. Naloxegol is an orally bioavailable, pegylated derivative of naloxone. Pegylation reduces its ability to cross the blood-brain barrier, and it is expelled from the brain by the P-glycoprotein efflux pump, resulting in primarily peripheral effects. Its half-life ranges from 6 to 11 hours. Methylnaltrexone is another medication administered parenterally. It acts peripherally and does not cross the blood-brain barrier. The difference in duration of action has significant clinical implications. If a short-acting antagonist like naloxone is given for a long-acting opioid agonist, like methadone, opioid effects may recur, residation, necessitating continuous monitoring. Naloxone is a fundamental therapy, especially in the treatment of opioid overdose. Pharmacy education highlights the importance of thoroughly understanding its historical development, unique pharmacological properties, various clinical uses, and essential safety considerations. The history and development of naloxone trace back to its synthesis in 1960, marking a significant milestone among opioid antagonists. Its creation was based on the understanding that minor structural changes to opioid receptor activators could produce antagonist activity. Naloxone, along with naltrexone, is derived from oxymorphone, with its antagonist effects resulting from the addition of specific functional groups. Since the mid-1990s, coinciding with the resurgence of the opioid epidemic, there has been a steady rise in the use of naloxone. It has been increasingly prescribed or directly dispensed to individuals at risk of overdose and for administration by bystanders. Naloxone is a pure competitive antagonist of opioid receptors, including the mu, kappa, and delta subtypes. It binds effectively to these receptors and exerts its most significant activity at the mu receptor. Higher doses of naloxone are typically required to influence the kappa and delta receptors. As a competitive antagonist, naloxone prevents opioid agonists, partial agonists, or mixed agonist-antagonists from binding to these receptors, thereby reversing the effects of opioids without producing any effect of its own. In patients who have not previously used opioids or who are not dependent on opioids, naloxone has no significant effect. Naloxone has a relatively short duration of action, lasting approximately 20 to 90 minutes. This is significantly shorter than naltrexone, which remains active for about 24 hours. This difference is important because it means that opioid effects may recur or residation may occur, especially when naloxone is used to reverse the effects of long-acting opioid agonists such as methadone. Naloxone must be administered through a parenteral route because of its extensive first-pass hepatic elimination. It can be given via intramuscular, intravenous, endotracheal, subcutaneous, intranasal, or intraosseous routes. Its oral bioavailability is very low, less than 2%, while rectal administration provides about 15% bioavailability and sublingual administration about 10%. The medication is well absorbed through all parenteral routes, with a rapid onset of effects, often within 1 to 2 minutes when given intravenously. In terms of metabolism and elimination, naloxone is processed primarily in the liver, including conversion to a glucuronide conjugate. The elimination half-life after intravenous administration in adults ranges from 60 to 90 minutes. In neonates, this half-life can be 2 to 3 times longer. Naloxone is the primary opioid antagonist used to reverse life-threatening respiratory depression and central nervous system depression in patients showing signs of opioid toxicity. It effectively corrects most symptoms associated with opioid poisoning, including pain relief, constricted pupils, inhibition of baroreceptors, dilation of blood vessels, and slowed gastrointestinal movement. Reversing respiratory depression caused by buprenorphine with naloxone is less predictable and follows a nonlinear, bell-shaped dose-response curve. While a dose of 2 to 4 milligrams of naloxone administered intravenously can be effective, doses exceeding 5 milligrams may paradoxically reduce the reversal effect and worsen respiratory depression. When treating buprenorphine toxicity, the initial intravenous dose should be between 1 and 2 milligrams and should be carefully titrated. The total dose should not exceed 5 milligrams in an adult. Toxicity from highly potent phenyl derivatives may require higher doses of naloxone, potentially ranging from 2 to 10 milligrams, to achieve reversal due to their increased potency. Because the effects of naloxone are short-lived, it is necessary to perform continuous cardiorespiratory monitoring after administration. This monitoring should include end-tidal capnography, which measures levels of carbon dioxide in expired air to help detect recurrent sedation and respiratory depression. If the patient experiences resedation, additional doses of naloxone or a continuous infusion may be required. The infusion should be initiated at 2/3 of the initial reversal dose on an hourly basis. Harm reduction and community-based opioid overdose prevention programs increasingly advocate for the administration of naloxone by laypersons. These programs offer education on recognizing and responding to overdoses, including the timely administration of naloxone through either intramuscular or intranasal methods. Research supports the effectiveness of trained laypersons in safely administering naloxone, which in turn helps reduce the morbidity and mortality associated with overdose incidents. Policy reforms, such as laws similar to the Good Samaritan laws and regulations allowing pharmacists to dispense naloxone without a prescription, are designed to improve the availability of naloxone. The United States Department of Health and Human Services emphasizes the importance of enhancing access to naloxone. Other uses of naloxone include its application in the treatment of opioid use disorder. Naloxone is often combined with buprenorphine in sublingual formulations, such as Suboxone, to help prevent intravenous abuse. Additionally, very low doses of naloxone have been found to enhance the analgesic effects of opioids such as morphine, methadone, and buprenorphine. This paradoxical effect can also help reduce the development of tolerance and dependence, as well as minimize opioid-related adverse effects like nausea, vomiting, constipation, and itching. This is believed to occur because of the selective inhibition of certain excitatory opioid receptors. In cases of overdoses involving non-opioid substances such as alcohol, clonidine, or captopril, opioid antagonists may be used, although their effects tend to be less consistent and pronounced than in opioid overdoses. The proposed mechanism involves the reversal of endogenous opioid peptides at the opioid receptors. Finally, low doses of opioid antagonists can be employed to treat itching caused by morphine and similar opioids. Naloxone, also known by its brand name Narcan, is available in various formulations. It can be found in different injectable concentrations, including 0.4 milligrams per milliliter and 1 milligram per milliliter, which come in ampoules, vials, and syringes. There is also an auto-injector containing 2 milligrams of the medication. For intranasal administration, naloxone is available as a 1 milligram per milliliter solution that uses a mucosal atomizer device to deliver the medication. Additionally, there are intranasal devices that contain either 2 milligrams in 0.1 milliliters or 4 milligrams in 0.1 milliliters. Naloxone remains stable in a solution of 9 parts sodium chloride to 1 part water for up to 24 hours when used for continuous intravenous infusion. Despite the common citation of a 2 milligram dose of naloxone in many resources, it is important to recognize that this is not the recommended dose according to a significant number of toxicology experts. Their research and expertise have identified several valid reasons to avoid such a high dose. One reason is to minimize withdrawal symptoms. Administering high doses of naloxone to patients dependent on opioids can cause severe and sudden withdrawal effects. Starting with a low dose and gradually increasing, it helps to prevent or lessen the severity of these symptoms. Withdrawal can include vomiting, agitation, high blood pressure, and a rapid heart rate, which complicate patient management and can potentially become life-threatening. Another reason for using lower initial doses is the flexibility it provides in dosing adjustments based on the patient's response. Beginning with a small dose allows healthcare professionals to titrate upward carefully, ensuring adequate ventilation while reducing the risk of withdrawal. Although lower doses of naloxone may extend the time before spontaneous breathing returns, safe and effective interim ventilatory support can be provided during this period. This support enables the use of lower initial doses and further diminishes the likelihood of withdrawal symptoms. Remember that the main goal when administering naloxone is to restore proper breathing, rather than ensuring complete consciousness. The suggested dose of 0.04 milligrams offers a balanced approach. It effectively reverses respiratory depression while minimizing the risks associated with sudden withdrawal symptoms. The primary focus remains on restoring adequate ventilation as the key objective of this treatment. The appropriate dose of naloxone varies depending on the specific circumstances. When there is a suspicion of opioid dependence, an initial dose of 0.04 milligrams administered intravenously is recommended. This low dose helps to prevent or minimize precipitated withdrawal symptoms. Additional doses can be given every 1 to 2 minutes, with titration upward until the patient responds or shows signs of withdrawal. In cases where opioid dependence is unlikely, such as during an acute opioid overdose, a starting dose of 0.4 milligrams intravenously is typically effective in reversing respiratory depression caused by most opioids. For pediatric patients without opioid dependence, the initial dose is similar to that used in adults, starting at 0.1 milligrams per kilogram of body weight, up to a maximum of 2 milligrams. If the patient's response to lower doses is inadequate, the naloxone dose can be increased incrementally. Doses of 0.2 or 0.4 milligrams can be administered, up to a total of 2 milligrams in adults. In cases where opioid overdose is still suspected, repeated bolus doses of 2 milligrams may be given, with the total dose not exceeding 10 milligrams. Patients exposed to ultra-potent opioids, such as fentanyl derivatives that are significantly more potent than morphine, may require very high doses of naloxone. There have been reports of patients responding to doses as high as 10 milligrams after administration of ultra-potent opioids. For pediatric patients with suspected opioid dependence, a more cautious approach is recommended, starting with a dose of 0.04 milligrams and providing supportive care. The goal of naloxone therapy is to restore sufficient spontaneous breathing rather than achieving complete consciousness. Careful dosing of naloxone is essential, particularly in patients dependent on opioids, to prevent the potentially harmful effects of sudden withdrawal symptoms. Patients should be closely monitored for signs of respiratory depression or sedation reoccurring, especially after receiving higher doses or when long-acting opioids are involved. The statement that naloxone cannot displace buprenorphine from its binding site is an oversimplification. Although buprenorphine has unique binding characteristics that make it challenging for naloxone to displace it, the process is possible. However, the reversal of buprenorphine's effects by naloxone can be unpredictable and may require careful dose management. Buprenorphine exhibits an extremely high affinity for the mu-opioid receptor, meaning it binds very strongly to this receptor site. Additionally, it has a slow rate of dissociation from the receptor, allowing it to remain bound for a longer duration compared to other opioids. The combination of these two properties makes it challenging for naloxone, a competitive antagonist, to fully displace buprenorphine from the receptor site. The bell-shaped dose-response curve describes a phenomenon in pharmacology where increasing the dose of a drug initially produces a greater response, but beyond a certain point, further increases can lead to a reduction in effect. Standard doses of naloxone, which are typically effective in reversing the effects of various opioids, may not be effective when used to reverse buprenorphine. While increasing the dose of naloxone can be effective within a specific range, administering a higher dose beyond this range may paradoxically worsen respiratory depression. This unusual response is referred to as a bell-shaped dose-response curve. Although the precise mechanism behind this phenomenon is not fully understood, it underscores the complex interactions at the receptor level between buprenorphine and naloxone. The theory of partial agonism and antagonism suggests that buprenorphine may have different effects on subtypes of the mu-opioid receptor. It functions as a partial agonist at lower concentrations, providing some receptor activation, and acts as an antagonist at higher concentrations, blocking receptor activity. Consequently, administering excessive amounts of naloxone, an opioid antagonist, could potentially interfere with buprenorphine's antagonistic effects, which might worsen respiratory depression. Clinically, the challenge in displacing buprenorphine from its binding sites has important implications. When reversing a buprenorphine overdose, careful titration of naloxone is essential. It is advised to begin with a slightly higher initial dose, such as 0.02 milligrams per kilogram of body weight or 1 milligram in an adult, and then gradually increase the dose in small increments. Because the duration of action of naloxone is shorter than that of buprenorphine, close monitoring of the patient is necessary to watch for signs of resedation. Repeated administrations of naloxone or a continuous infusion may be required to maintain effective reversal of the overdose. While both naloxone and naltrexone are opioid antagonists, several factors make naltrexone unsuitable for reversing opioid overdose despite its theoretical potential for single-dose reversal of opioid poisoning. Naltrexone has a long duration of action, lasting approximately 24 hours. This extended period can significantly risk triggering an intense and prolonged withdrawal syndrome in individuals who are dependent on opioids. The reason for this is that naltrexone's prolonged occupation of opioid receptors can completely and suddenly block the effects of opioids that the patient depends on. In comparison, naloxone has a much shorter duration of action, typically between 60 and 90 minutes. This shorter duration allows for a more gradual reversal and better titration, which can reduce the severity and duration of withdrawal symptoms. Naltrexone has long-lasting effects, which can make it difficult to carefully adjust the dosage to achieve enough reversal of opioid effects without causing severe withdrawal symptoms. Once administered, its effects are not easily reversible or adjustable. In contrast, naloxone has a shorter duration of action, allowing for more precise control over the dosage and easier management of potential withdrawal symptoms. Naloxone can be given in small, incremental doses, and its effects can be more readily reversed if necessary. The potential for adverse cardiovascular effects arises from the use of naltrexone, which can cause a sudden and complete blockade of opioid receptors. This blockade may lead to a surge in catecholamines, the stress hormones, particularly in individuals dependent on opioids. Such a surge can result in adverse cardiovascular outcomes including high blood pressure, rapid heart rate, and even irregular heart rhythms. While naloxone, another medication that can cause similar effects, also carries these risks, its shorter duration of action and easier titration reduce both the likelihood and severity of adverse cardiovascular events compared to naltrexone. Delayed onset of action can be a concern with naltrexone due to its limited oral bioavailability caused by extensive first-pass metabolism. This results in a slower onset of action compared to naloxone administered intravenously. In emergency situations, especially those involving overdose, this delay could be detrimental as rapid reversal of respiratory depression is often critical. Naltrexone is primarily available in oral formulations and is not ideal for emergencies requiring rapid drug delivery. Conversely, intravenous naloxone provides immediate access to the bloodstream and a faster onset of action, making it a more suitable choice for urgent scenarios. There is a lack of evidence supporting the safety and effectiveness of using naltrexone for reversing acute opioid overdose. Although naltrexone is commonly used to prevent relapse in individuals recovering from opioid addiction after detoxification, its application in the context of an overdose has not been well studied. Using it in this setting could potentially result in unpredictable and harmful outcomes. However, there may be specific, carefully considered situations in which naltrexone could be appropriate. For instance, unintentional exposure to short-acting opioids in individuals who are not dependent on opioids, especially children, might warrant such use. In these cases, extended observation periods are necessary to ensure that no delayed opioid toxicity occurs after the medication wears off. Adverse effects and safety issues associated with opioid antagonists are significant and require careful consideration. One of the most serious adverse effects occurs when antagonists are administered to individuals dependent on opioids. This can lead to precipitated opioid withdrawal, with symptoms ranging from mild discomfort to severe, potentially life-threatening conditions caused by a surge of catecholamines. Such severe reactions may include cardiac dysrhythmias and acute lung injury. Another concern is unmasking other toxicities. Rapid reversal of opioid effects using antagonists like naloxone can reveal underlying stimulant toxicity, such as from cocaine when combined with opioids in a so-called speedball. This situation can potentially lead to cardiac arrhythmias or seizures. Re-administration of naloxone or similar agents may also result in resedation. Since the duration of action of naloxone is shorter than that of many opioid agonists, there is a risk of recurrent respiratory depression and sedation after initial reversal. This necessitates prolonged observation or even continuous infusion to ensure patient safety. Finally, in patients who are not dependent on opioids, pure opioid antagonists generally produce no clinical effects, even at high doses. However, very large doses, such as 2 milligrams per kilogram, have been reported to cause symptoms like anxiety, difficulty concentrating, sadness, irritability, sweating, and gastrointestinal manifestations. These symptoms may persist for days after administration. A comprehensive understanding of opioid overdoses goes beyond just pharmacology. It also includes important prevention, treatment, and harm reduction strategies. The increasing number of deaths related to opioids is driven by both the misuse of prescription medications and the rise of illegal substances such as fentanyl and heroin. This situation requires a coordinated and multifaceted public health response. Efforts to prevent opioid overdoses are vital in reversing the ongoing opioid crisis. Prevention strategies should focus on reducing initial exposure to opioids and addressing known risk factors associated with overdose. By implementing these measures, it is possible to make significant progress in curbing the rising tide of opioid-related deaths. Addressing prescribing practices. The prescribing habits of physicians have been recognized as a significant factor contributing to the widespread misuse of opioids over the past 20 years. Although there is limited data supporting the long-term safety and effectiveness of opioids for managing chronic pain, many doctors continue to prescribe them for pain that is not related to terminal conditions. This practice has led to high rates of opioid use disorder. The Centers for Disease Control and Prevention has issued guidelines aimed at improving the management of chronic pain. These guidelines recommend considering alternative medications and therapies, engaging in discussions about addiction risks with patients, favoring the use of short-acting opioids, regularly reassessing pain levels and the patient's functional status, and screening patients for opioid use disorder and diversion. Research indicates a clear link between prescribing opioids for acute pain and the subsequent development of long-term opioid use. The risk of becoming a long-term user increases sharply during the first few days of treatment. This highlights the importance of carefully weighing the potential risks and benefits of opioid therapy, even when it is prescribed for short-term pain management. Opioid overdose is usually characterized by oversedation, hypoventilation, and a lack of oxygen in the brain due to an excessive dose of an opioid drug. This situation is often worsened when combined with other central nervous system depressants. Prevention efforts focus on several well-established risk factors. One major risk factor involves individuals with opioid dependence, particularly those who have experienced a period of reduced use followed by a loss of tolerance. This situation often occurs after detoxification, release from incarceration, or when stopping recovery treatments. Another vulnerable group includes people who inject opioids. Patients who are prescribed opioids are also at risk, especially those receiving higher doses. Additionally, co-administration of opioids with other sedating substances, such as benzodiazepines, alcohol, or cocaine, increases the risk of overdose. Individuals with certain medical conditions, including HIV, liver diseases, lung diseases, or depression, are also more susceptible to overdose. Household members, including children, of individuals who possess opioids, whether they are prescription medications or not, are at risk due to accidental exposure. Patients suffering from obstructive sleep apnea, a condition that affects breathing during sleep, are another vulnerable group. Preventive measures encompass increasing access to evidence-based treatments and harm reduction strategies, especially during critical times such as release from correctional facilities. Reforms and regulations aimed at reducing the rates and doses of opioid prescriptions are also crucial in addressing this public health issue. Harm reduction focuses on practical strategies to reduce the negative consequences associated with opioid use, with a strong emphasis on naloxone. Naloxone is the primary intervention used to address opioid overdoses. It is administered by individuals who are trained, including at-risk opioid users, those in treatment, family members, friends, workers at homeless shelters, staff involved in substance abuse treatment, and first responders. Community-based programs play a crucial role in overdose prevention. Since most opioid overdoses happen in the presence of a bystander, often in private settings, these programs focus on educating the public about recognizing overdose signs quickly and responding effectively. Training covers topics such as administering naloxone promptly, performing rescue breathing, using recovery positioning, and activating emergency medical services. Research indicates that laypersons who receive training are capable of recognizing opioid overdoses and administering naloxone safely and properly. Cohort studies have shown these programs are effective in reducing deaths related to opioid overdose. Some studies report significant decreases in overdose death rates and survival rates ranging from 83 to 100% after naloxone was administered. Enhancing access to naloxone for emergency overdose rescue is also a priority for the United States Department of Health and Human Services. There are some controversies surrounding the increased availability of naloxone. Some individuals worry that broader access to this medication might lead to higher drug use or risk-taking behaviors, a concept known as the Peltzman effect. However, research studies have not supported this concern. In fact, some communities have even observed a decrease in drug use when access to naloxone was expanded. Another issue is the potential for naloxone administration to reduce the perceived need to call emergency services by activating emergency medical assistance. Despite this concern, activation rates for emergency services vary across different communities. Moreover, one of the primary reasons cited by individuals for not calling emergency services is the fear of police involvement. Policy reforms across many states are aimed at increasing the availability of naloxone, a medication used to counteract opioid overdoses. These reforms include measures to reduce liability concerns for healthcare providers who prescribe or dispense naloxone, thereby encouraging its wider use. Additionally, some states permit third-party or standing prescriptions, which allow healthcare providers to issue naloxone prescriptions to individuals other than the patient, expanding access. Regulations have also been expanded to enable non-medical providers and laypersons to administer naloxone, recognizing the critical role they can play in emergency situations. Efforts are ongoing to allow pharmacists to dispense naloxone without a prescription or make it available over the counter, further improving accessibility. Legal protections, such as Good Samaritan laws, have been implemented to shield laypersons who administer naloxone and activate emergency medical services from legal repercussions. Moreover, the Comprehensive Addiction and Recovery Act of 2016 has included provisions to increase the availability of naloxone and provide training for first responders to effectively handle opioid overdoses. Safe injection sites and medical heroin interventions are controversial topics. Although they are prohibited in the United States, they are widely used in other countries around the world. Heroin-assisted treatment has demonstrated positive results in studies conducted in Europe and Canada, showing higher rates of patients remaining in treatment and lower self-reported levels of criminal activity among participants. In the North American Opiate Medication Initiative trial, overdoses among patients receiving heroin-assisted treatment, which involved over 70,000 injections, were effectively reversed using naloxone without any negative health outcomes. Treating opioid use disorder is a key approach to preventing overdose deaths and enhancing overall health outcomes. One of the primary strategies involves opioid agonist maintenance therapies, such as methadone and buprenorphine, which are supported by substantial scientific evidence and are considered first-line treatments for active opioid use disorder. These therapies work by keeping the patient on a consistent dose that either blocks or partly blocks the euphoric effects of additional opioid use. This mechanism helps reduce cravings and urges for illicit opioids. Methadone, which is classified as a full agonist, and buprenorphine, as a partial agonist, have been associated with lower mortality rates and reduced illicit opioid consumption compared to individuals who discontinue treatment. Buprenorphine is available in sublingual tablets or films, often combined with naloxone, a combination marketed under names such as Suboxone. This combination is used to prevent intravenous misuse of the medication. Extended-release naltrexone is a newer therapy approved by the Food and Drug Administration for the treatment of opioid use disorder. It is specifically designed to prevent opioid relapse after detoxification. The medication is administered as a monthly intramuscular depot injection, which helps improve patient adherence to the treatment regimen. This therapy works by blocking the effects of additional opioid use, rendering them ineffective and non-euphoric. Patients must be detoxified and free of opioids at the time of initiating this treatment. A study involving criminal justice offenders found that those receiving this therapy experienced a lower rate of combined fatal and non-fatal overdose outcomes. Counseling-only treatments have some advantages and respect patient preferences for a drug-free recovery. However, these modalities also elevate the acute risk of overdose. When individuals detoxify from opioids and transition to counseling-only approaches, they often experience a loss of tolerance. This loss significantly increases the risk of overdose if the individual relapses. Multiple studies demonstrate that counseling-only treatments are associated with higher rates of opioid relapse, overdose, and death compared to medication maintenance approaches. Due to these concerns, recent federal initiatives consider counseling-only approaches inadequate and potentially counterproductive in addressing the opioid overdose epidemic. Overall policy and practice reforms related to the opioid crisis involve ongoing development and assessment of various initiatives. Efforts aimed at reducing the volume and supply of opioid analgesics include implementing prescription monitoring programs and rescheduling hydrocodone to a Schedule II controlled substance, with the goal of decreasing opioid prescribing and overdose incidents. Additionally, some states that have legalized medical marijuana and cannabis have reported lower rates of opioid overdose, suggesting that cannabis might play a role in reducing opioid exposure among individuals with chronic pain. These policies must be continuously evaluated and revised to ensure they effectively minimize harm and reduce the risk of overdose. Both methadone and buprenorphine are medications used in treatment programs for opioid use disorder. They are classified as opioid agonists, meaning they activate opioid receptors in the brain to reduce withdrawal symptoms and cravings. While these two drugs share similarities in their use, they also have distinct pharmacological properties and clinical considerations that differentiate them. Understanding these differences is important for ensuring the most effective treatment approach for individuals with opioid dependence. Methadone is a full agonist of the mu-opioid receptor, meaning it fully activates this receptor to produce effects similar to other strong opioids like heroin or morphine. It is a synthetic opioid known for its long-lasting effects, typically lasting around 24 hours. Buprenorphine, on the other hand, is a partial agonist of the mu-opioid receptor. This means it binds to the receptor but produces a less potent effect compared to full agonists. Additionally, buprenorphine exhibits antagonistic effects at the kappa and delta opioid receptors and interacts with receptors similar to opioid receptors. It is a semisynthetic drug with a long duration of action, although this is shorter than that of methadone. The section on safety and side effects discusses the risk of respiratory depression associated with two opioids used for treatment. Methadone carries a higher risk of causing respiratory depression, particularly during the initial stages of treatment or in cases of overdose. This is because its effects on the respiratory centers in the brain are stronger than those of buprenorphine. In contrast, buprenorphine has a ceiling effect on respiratory depression, meaning that increasing the dose beyond a certain point does not proportionally increase the risk of respiratory depression. This characteristic makes buprenorphine safer in overdose situations compared to methadone. Methadone is a medication known to prolong the period it takes for the heart to recharge electrically, which is measured by the QT interval. An extended QT interval can lead to dangerous heart rhythm abnormalities that may be fatal. This risk is particularly significant in individuals who already have heart conditions or who are taking other medications that influence the QT interval. In contrast, buprenorphine does not significantly affect the QT interval, making it a safer alternative for patients with concerns about their cardiac health. Both methadone and buprenorphine can cause withdrawal symptoms if they are discontinued abruptly. However, buprenorphine's high affinity for mu receptors can precipitate severe withdrawal symptoms if it is started too soon after using other opioids. This is because it can displace other opioids from the receptor site and prevent them from binding. In the United States, methadone used for medication-assisted treatment can only be dispensed through licensed opioid treatment programs. This restriction exists because methadone has a higher potential for abuse and diversion. Initially, patients typically need to attend these clinics daily to receive their doses. Buprenorphine no longer requires a waiver from the Drug Enforcement Administration and is classified as a Schedule III controlled substance. When selecting a treatment approach, it is important to consider individual patient factors, preferences, and clinical circumstances. The choice between methadone and buprenorphine should be tailored to each patient. Patients with a history of severe opioid dependence or those who have not responded well to buprenorphine may benefit more from methadone due to its higher potency. In addition, the presence of other medical conditions can influence medication choice. Buprenorphine is often preferred for patients with cardiac concerns or those taking medications that prolong the QT interval, as it does not have these effects. Both medications can be used during pregnancy, but methadone is generally favored because of its more extensive history of use in pregnant women. Careful induction and titration are essential when starting either medication. These steps help minimize side effects and ensure the treatment is effective. Overall, an individualized approach that considers all these factors is key to achieving the best outcomes in opioid dependence treatment. Both methadone and buprenorphine are effective medications used in the treatment of opioid dependence. They help reduce the use of illegal opioids, support patients in staying enrolled in treatment programs, and decrease criminal behavior and deaths caused by overdoses. Research comparing these two medications has produced mixed results. Some studies suggest that methadone may be slightly more successful in helping patients remain in treatment, especially for those with more severe forms of opioid dependence. This content provides a comprehensive overview of opioids, their pharmacology, clinical effects, and management strategies, crucial for pharmacy education. Key terminology and history. The curriculum clarifies the distinction between opiates, natural alkaloids like morphine, codeine, opioids, a broader class including endogenous, natural, semisynthetic, and synthetic compounds, and the often misused term narcotics. The medicinal use of opium dates back to ancient times, with morphine isolated in 1804 and heroin in 1874. Societal concerns over abuse led to legislative actions like the Harrison Narcotics Tax Act of 1914. The modern opioid epidemic has evolved from prescription opioid surges to a rise in heroin use, and most recently, a sharp increase in synthetic opioids like fentanyl. The development of opioid receptor antagonists began in the 20th century, culminating in naloxone, 1960, and naltrexone, 1963. Opioid pharmacology. Opioids primarily exert their effects by binding to three major G-protein-coupled receptor subtypes, mu, kappa, kappa, and delta, delta symbol. Mu receptors, MOP, mediate supraspinal analgesia, euphoria, 1, and critically, respiratory depression, meiosis, constipation, and physical dependence, 2. Kappa, kappa, receptors, KOP, are involved in spinal analgesia, meiosis, diuresis, kappa 1, and can cause dysphoria and psychotomimesis, kappa 2. Delta, delta symbol, receptors, DOP, contribute to spinal and supraspinal analgesia and cough suppression. Opioids can be classified as natural opiates, semisynthetic opioids, synthetic opioids, partial agonists, e.g., buprenorphine, mixed agonist-antagonists, e.g., pentazocine, or antagonists, e.g., naloxone, naltrexone. Clinical presentation of opioid toxicity. The classic opioid toxic syndrome includes depressed mental status, reduced ventilatory rate, hypoventilation, meiosis, pupillary constriction, and decreased bowel motility. Respiratory depression is the primary adverse event and leading cause of death. Seizures are a rare but serious manifestation, often drug-specific, e.g., normeperidine metabolite of meperidine, tramadol, or due to hypoxia. Other effects include cardiovascular changes, hypotension, bradycardia, QTc prolongation with methadone, acute respiratory distress syndrome, ERDS, and in the case of fentanyl, chest wall rigidity. Diagnosis is primarily clinical, with patient history and response to naloxone being key. Unique effects of individual opioids. Meperidine has a proconvulsant metabolite, normeperidine, and can cause serotonin toxicity. Tramadol and tapinadol have dual mechanisms, opioid and monoamine reuptake inhibition, and can cause seizures. Fentanyl is highly potent, can cause chest wall rigidity, and may require higher doses of naloxone. Methadone is very long-acting, a full opioid agonist, and carries a risk of QTc prolongation. Buprenorphine is a partial opioid agonist with high receptor affinity, used in medication-assisted treatment, MAT, and its respiratory depression exhibits a ceiling effect. Naloxone reversal of buprenorphine is unique and can follow a bell-shaped dose-response curve. Opioid antagonists. Naloxone is the primary antagonist for reversing acute opioid overdose, with a short duration of action, 20 to 90 minutes. It is a competitive antagonist at kappa and delta receptors, with highest potency at. Dosing should be carefully titrated, e.g., starting at 0.04 milligrams for suspected dependence, to restore adequate ventilation while minimizing precipitated withdrawal. Naloxone distribution to laypersons is a critical harm reduction strategy. Naltrexone is a long-acting opioid antagonist, 24 hours, used for relapse prevention in opioid use disorder, OUD, and alcohol dependence. It is generally unsuitable for acute overdose reversal due to the risk of precipitating severe, prolonged withdrawal and cardiovascular effects. Peripherally restricted antagonists like methylnaltrexone and naloxegol are used to treat opioid-induced constipation without causing central withdrawal. Prevention and harm reduction strategies. Prevention efforts include addressing inappropriate opioid prescribing practices, e.g., CDC guidelines, and targeting risk factors such as opioid dependence, high doses, co-administration with other sedatives, and comorbidities. Harm reduction prioritizes naloxone distribution and education for at-risk individuals and bystanders, supported by policy reforms like Good Samaritan laws and expanded pharmacist dispensing. Treatment of OUD using opioid agonist maintenance therapies like methadone, full agonist, dispensed through OTPs, QTc prolongation risk, and buprenorphine, partial agonist, ceiling effect on respiratory depression, often co-formulated with naloxone, is a primary overdose prevention strategy. Extended-release naltrexone is also used for relapse prevention post-detoxification. Counseling-only treatments, while offering a drug-free approach, elevate the acute risk of overdose due to loss of tolerance. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.